Okay, I think we might start. We've got a good number of people online today, and so welcome to Pediatric Teaching. Last week we talked about fluid management in common infections in children, and we went through the pathophysiology of different febrile illnesses and how they can influence fluid requirements and how we need to adjust our management according to that. This week, I just wanted to speak about one particular topic, and that's the fluid resuscitation in sepsis or septic shock. And that's, I think this is a separate question to the issue about what sort of maintenance fluid to give children, because there's a lot of talk about what type of fluid resuscitation children who've got shock or septic shock should receive. Now, to start with, I just wanted to show one video of a child. We'll just see if we can bring that up now. One video of a child. We'll just go through this video. Just look at this boy. And it's all okay. I might show that video just one more time so you can just look at the clinical signs the child has and try to really think to yourself what's the condition the child's got and how severe is it. If you were seeing this child in an emergency department or in your outpatient's clinic, the child had just been brought to your emergency department, I want you to think about the way you would consider this child. You would triage this child. I'm just going to stop there and I want you to think about the clinical signs this child has. So remember, when we're seeing a child at triage, we need to think about airway, breathing, circulation, and conscious state. They're the only four things we need to think about: A, B, C, D. D being for disability, but it's conscious state is good enough. This child is deeply unconscious. He's not responding to the things going on in his environment. Do you think his airway is safe at the moment? What do you think? But at the moment, he doesn't seem to have airway obstruction, but he's lying flat on his back and he's unconscious. So any child lying flat on their back and unconscious, they will vomit and they might aspirate. So even though his airway is not obstructed, his airway is at risk from aspiration. So something needs to be done about that. Regarding his breathing, what is it you noticed about his breathing? I can show a bit more of the video if you like, just to see. Try to notice something about his breathing. Got the mannitol in. I'll show. Got the mannitol in. Yeah. I think you would have noticed that he doesn't have the normal tidal breathing that a child would have. He's having gasping breathing every now and again, isn't it? His breathing rate is probably not very fast, but he's gasping with every breath. So he's unresponsive to he's unresponsive to the noise or the talking that's going on around him. His airway is stable at the moment, but he's lying flat on his back and he's deeply unconscious. And so his airway's at risk. And with his breathing, he's got gasping type of breathing. Now, what about his circulation? Just look at him again and just try to comment on his circulation. We'll try again. Remember, when you're assessing a child's circulation, you can feel their hands and their feet. And when you're feeling their hands, you can feel whether they're warm or cold. You should feel their pulses to feel whether they've got a strong volume pulse or it's a weak volume pulse. You should check their capillary return to see if it's prolonged or not, more than 2 seconds or less than 2 seconds or less. And of course, you can measure the child's blood pressure if you have a blood pressure cuff available. But if you don't have that, then an assessment of the circulation can be just based on an assessment of the hands and the feet and the child's level of consciousness. So what do you think this boy's hands and feet felt like? Well, when you look at him, you wouldn't imagine that his hands and feet would be warm. In fact, his hands and feet were very cold, and his pulses were very difficult to feel, and his capillary return was very long. If you look at the rest of his skin, you can see how mottled his skin is, and see how he's got these sort of bruising on his skin. It appears like bruising. So can anyone suggest what might be wrong with this boy? Well, there's a number of things he could have, but when you see a child like this, poorly conscious with mottled skin, cold hands and feet, difficulty with breathing or gasping respiration, you should think to yourself, this is septic shock until proven otherwise. Of course, it could be other things, but a starting point in the management of this child is to consider this child as to have severe sepsis until proven otherwise. All right. And so I think it's an important, we focus a lot on what the clinical signs are of respiratory distress or pneumonia, what the clinical signs are of dehydration, but we don't focus quite as much on severe sepsis. And this child has severe sepsis, and it's probably meningococcal sepsis. Now, these days we're seeing a lot more gram-positive sepsis. Meningococcus is a gram-negative bacteria, but this boy, because of his bruising and purpura on his skin and the mottling, probably has meningococcal sepsis. But the main thing is to recognize that this is severe sepsis until proven otherwise, and then decide what to do about it. All right, this is what we're going to talk about today, what to do about it. So, as I said, the definition, the World Health Organization definition of shock is tachycardia with prolonged capillary refill. Often it's much longer than 2 seconds. It might be 4 or 5 seconds. Weak peripheral pulses. And I think if it's a good idea throughout your training and experience to get used to feeling the pulses of children of all ages, feeling normal pulses like the peripheral pulses, the radial and the foot pulses, because when you do that, you understand what the pulses should feel like in normal children. And then when you see a child in shock, you'll know how different they are. So get used to feeling the hands and the feet, feel whether the hands are warm or cold, the peripheral pulses and the capillary return. And then you'll be able to diagnose shock. And if you can, then measure the blood pressure. That's an important thing to do. Now, in terms of fluid, these children need a rapid infusion of 10 to 20 mils of fluid. Now, we talked last week about the types of fluid that we should be giving to children. And we said how there are certain fluids that you shouldn't give, like 4.3% dextrose and 1/5 normal saline. But there are some other fluids that are good to give, such as Hartmann's solution or Ringer's lactate. Normal saline and dextrose is okay to give, but Hartmann's solution and Ringer's lactate are probably the best ones. But the recommendation now is to give 10 to 20 mils per kilo of fluid and then reassess. And that's the recommendation for reasons which I'm going to explain in the next few slides in the next 5 minutes, because that's what we used to do a long time ago. We used to do that, 10 to 20 mils per kilo of fluid over 30 to 60 minutes and then reassess. But first of all, to consider that there are many types of shock, and some types of shock need more fluid and some types of shock need less fluid. Now, of course, hypovolemic shock most commonly occurs from vomiting and diarrhea. If you see a child who's got profuse diarrhea for several days and they're in shock, then they're going to need a lot more than 10 or 20 mils per kilo of fluid. But that's a good start, 10 or 20 mils per kilo of fluid. And then you can take a history and then you can try to differentiate the shock. Is it hypovolemic shock? Is it septic shock? In the case of trauma, or sometimes in the case of some illnesses, it could be hemorrhagic shock. Or could it be the child's got cardiogenic shock? Their heart's failing because they've got rheumatic heart disease or congenital heart disease? Or do they have some other form of shock that's led to cold peripheries and weak pulses and prolonged capillary refill? So they're all the different types of shock. But as I said, each one of those, you won't hurt the child by giving 10 to 20 mils of fluid just over 30 to 60 minutes. And then in that hour, then the child will need antibiotics and they'll need a reassessment. They'll need you to take a good history and do a proper examination and then try to differentiate the type of shock that the child has. The reason I wanted to emphasize that volume of fluid is because there was, in the last 20 years, there's been a push to give more fluid than that. And that started with this paper. I won't go into the details, but this was a good paper that was published, but only on 34 patients. And in this paper, they identified that children who got more than 20 mils per kilo of fluid, often it was 40 mils per kilo of fluid or even 60 mils per kilo of fluid, apparently they did better in this study. But this was a study that was done in North America, where they had access to intensive care and they had access to mechanical ventilation and other things. If the child got extra fluid on their lungs or they developed edema, then that's what they would do. So the problem was that up until this paper, the children were getting 10 to 20 mils per kilo of fluid over 20 to 30 minutes, and then they were being reassessed. But in this paper, they got more fluid, 40 to 60 mils per kilo of fluid, and they appeared to have a better outcome. But 80% of these children were ventilated, and they were all in a high technology intensive care unit. Now, the problem with that paper is that it led to, around the world, people started giving more than 10 or 20 mils per kilo of fluid. They started giving 40 or 60 mils per kilo of fluid. And it resulted in a large study that was done in Africa. And it was randomizing children to either getting 20 to 40 mils per kilo of fluid, even up to 60 at one point in the study, or getting no bolus of fluid, no extra fluid, just normal maintenance fluid. The problem was that most of these children didn't even have shock. They didn't have all of these clinical signs. And what that meant was that they had other illnesses like pneumonia or bronchiolitis or severe malaria. They didn't have septic shock. They had other illnesses, most of them. Some had septic shock, but not many. Only 65 children out of the 3,000 that were in this study fulfilled the criteria for shock. Others had other illnesses like pneumonia and malaria. There were 3,000 children enrolled in this study in Uganda and Kenya and Tanzania. They all had a febrile illness, and they all had one or more signs. They didn't have all the signs, but they didn't need to have all the signs, but they only needed to have one sign. And they were randomized to either getting that bolus of fluid with saline or albumin, which is a bit similar. Albumin is like a protein that comes in saline, or they were randomized to getting no bolus. And everybody in this study, all the investigators, who were all emergency department physicians in Western countries, expected the children who got the bolus to do better, but they didn't. They did much worse. And they did worse. This is what's called a Kaplan-Meier curve, which shows when children died in this study. And what you can see is that this was the arm of the study where there was no bolus given, right? And this was the arm of the study where either there was a bolus given with albumin or saline. And remember, it was 40 mils per kilo of fluid. That was what they received. And you can see a big difference between the outcomes for these two groups of children. And the children that got the large bolus of fluid did much worse. This was in the first 48, what I showed you was in the first month, but this was in the first 48 hours. And you can see that most of the extra deaths in those that received the large bolus of fluid occurred in the first 48 hours. And the mortality rate in those that received a bolus of fluid, a large bolus of fluid, was 12%. And in those that didn't receive a bolus of fluid, it was 8.7%. But as I said, most of these children didn't actually have shock. Some of them did, but not most of them. Most of them had malaria. Many of them had severe anemia, so a hemoglobin less than 5, very severe anemia. Some had severe acidosis. A quarter of them had severe hypoxemia. 15% were in coma. 7% were dehydrated, and only 6% were hypotensive, having shock. And so from that came a lot of questioning of whether or not giving any fluid to children with septic shock is valuable. And a lot more research was done. In that study I've just talked about was published in 2012, so quite some time ago. And then since then, there's been quite a lot of other research done, which shows that when you give a large bolus of fluid to children who've got a febrile illness, then about a third of them improve their blood pressure and their stroke volume because you're increasing their venous return to their heart. About a third get an improvement for the first 30 to 60 minutes. But then after that, the beneficial effect is gone because the fluid gets distributed into the tissues. The beneficial effect is gone after about an hour. About a third got no benefit on their blood pressure or their stroke volume. And for about a third, it was detrimental to their stroke volume and their blood pressure. And this all relates, I wanted to explain why that is, because it's like a pathophysiology question that you might get asked in the Part 1 examination. But it relates to this phenomenon called the Starling curve. And these are what I've drawn here are Starling curves. These are in fact called Sarnoff curves because Sarnoff was a scientist who followed Starling's method and gave fluid to patients and found that when you increase the left atrial pressure, you get an increase in stroke volume up to a point. Then after that, you get a plateau. That's the stroke volume because you're getting increased venous return. I wanted to show it in a bit more detail. So I've tried to draw Starling curves that show what happens when you've got normal cardiac function and what happens when you've got poor cardiac function. So when you've got normal cardiac function, if you give a volume bolus of fluid, then usually the stroke volume will increase more than the pressure in the left atrium. And it will increase for a period of time. So if you've got a normal heart and you're well, then mostly you'll get an increment in your cardiac function up until a point. And then if you keep giving more and more fluid, then it'll plateau and may even fall. But if you've got poor cardiac function, because the child's got sepsis or they've got rheumatic heart disease or they've got congenital heart disease or myocarditis, then their heart will function on a different Starling curve. And it won't be long after you start giving fluid to these patients that the effect on their stroke volume will be very diminished. So you'll increase the left ventricular pressure their preload on their heart, but the stroke volume will be small. The stroke volume increment, the benefit on stroke volume and cardiac output would be small. And then there comes a point when it actually makes it worse because your heart is failing. It's worse with a fluid bolus. So that's why a third get a benefit, but it's transient. A third get no response, and a third get a worse outcome when you give a large volume of fluid. What in that study that I talked about with 3,000 children, they did a reanalysis of the study and found that when you give large volumes of fluid to children with severe anemia, then you make their anemia worse. And that's not surprising because that volume of fluid will dilute their hemoglobin down. And so they might start with a hemoglobin of 5 and it ends up being a hemoglobin of 3. And that will reduce your oxygen carrying capacity of the blood. And it reduces because the hemoglobin gets diluted because of all the clear fluid that's being given. What those children need is a blood transfusion. They don't need clear fluid that dilutes their hemoglobin further. And it was also found that these children, especially if they have a sepsis syndrome, they may get pulmonary edema. They may get leakage of fluid into their lungs. So remember I said 25% of the children in the study were hypoxic. And if you give large volumes of fluid to children who are hypoxic, then it may make their lung water increase and it may worsen their hypoxia. And then if a child's got meningitis or encephalitis or cerebral malaria, then the capillaries in their brain will be a bit leaky. And if you give them a large volume of fluid over a short period of time, then the fluid may seep out into that and might cause cerebral edema. So those three complications of large volume, rapid intravenous fluid led to the excess deaths in the children in the African fluid bolus study. So since then, WHO has had more clear guidance what to do in children with who fulfill the criteria for septic shock. If they don't fulfill the criteria for shock, then just give them the normal fluid that you would give them, their normal maintenance fluid. Assess their hydration state and give them their normal maintenance fluid. But if they do fulfill the criteria for shock, that is, they've got cold hands, they've got poor volume pulses, they've got a prolonged capillary refill, they've got hypotension, then give them 10 to 20 mils per kilo of fluid over 30 to 60 minutes, and then reassess their airway, breathing, and circulation. And in that time, while you're giving that fluid, try to make a diagnosis. Try to differentiate the type of shock they have. Is it hypovolemic? Is it hemorrhagic? Is it cardiogenic? Is it septic? Try to differentiate the type of shock they have. Now, after that half an hour to an hour, if shock still persists, they're still hypotensive, then it's okay to give another 10 to 20 mils per kilo. But you need to start thinking about what else you could give to the child in shock, not keep giving them more and more and more fluid, because you'll end up only diluting their hemoglobin, giving them pulmonary edema, and may cause cerebral edema. If after the first volume of fluid over 30 to 60 minutes, the signs of shock have resolved and you don't find that they're hypovolemic from severe vomiting and diarrhea, then just give them normal maintenance fluid. You don't need to give them more and more boluses of fluid. And I think it's while you're giving that first lot of fluid, then think to yourself, well, what are the other causes of shock in children? What do we need to exclude? Now, of course, the most common cause of shock, I've listed the common causes up the top. Dehydration, severe dehydration, whether it's from gastroenteritis or cholera or severe vomiting, that's a common cause of shock. And the other common cause of shock is sepsis or septic shock. And you can think to yourself, is it maybe a gram-positive infection or a gram-negative infection or even a multi-resistant infection? Because those questions that you ask yourself relate to the other treatment you give, the antibiotics you give, for example. We see malaria, we see shock in malaria in some children, especially if they have a coexistent bacterial infection, the so-called sort of black water fever, where you get coagulopathy and severe shock. That's usually malaria with a severe bacterial sepsis as well. There are also some other causes of shock which we don't often think about. Some viruses can cause shock. We can see shock in children with influenza or enterovirus, sometimes because of their diarrhea, but also because it can cause a shock-like syndrome. There's another virus called parechovirus that sometimes causes shock. Sometimes anaphylaxis can cause shock. It causes a vasodilated distributive shock, where sometimes the instead of being cold and shut down, the child may be dilated and warm, but their blood pressure will be low. And so if you see a child like that, think, could they have had some anaphylaxis? And that could be to a food allergy or to shellfish or something like that. Yeah. Sometimes shock is cardiogenic. And so think, could this child who's in shock be having a cardiac arrhythmia, or could they have unrecognized rheumatic heart disease or congenital heart disease, or myocarditis from a viral infection or some other infection? Children who have diabetic ketoacidosis sometimes present in shock because they're so severely dehydrated. And it's something we don't often think about, diabetic ketoacidosis as a cause of shock, but obviously any child with shock, you need to measure their blood sugar. And often it's low because a child in shock may not have been eating for a while. But if you find the blood sugar to be very high, then think to yourself, maybe they've got diabetic ketoacidosis, and consider that. Measure their ketones or check their urine to see if they've got ketones. Sadly, sometimes we see children with trauma and even child abuse present in shock. There was a child actually just a month or so ago, wasn't there, who had severe trauma from physical and sexual abuse and developed shock, almost certainly because she had a severe septic shock on top of her, caused by her injuries. And so if you see a child who's in shock, then consider, perhaps, mostly you won't think about this, but occasionally we'll need to think, has this child been traumatized in some way as a cause of the shock? And then there's other causes of shock like snake bite that can cause shock with coagulopathy and all the clinical signs of shock. And then there's another condition called Kawasaki disease, which causes looks like septic shock. The children have a very high fever for many days, for 4 or 5 days, and they have a rash that looks a bit like scarlet fever. That's Kawasaki disease, which also, it occurs everywhere in the world. We just don't always recognize it. So while you're giving the first lot of fluid to these children, then think to yourself, well, what type of shock does this child has? Is it simply septic shock and we have to treat with antibiotics, or is it hypovolaemic shock and we've got to give fluids, or is it something more complex than that? That's our task in the first hour, to try to differentiate the cause of shock. So again, some of the things that you should be asking yourself are, should this child get more fluid if they're dehydrated? The first 10 or 20 mils per kilo, if they're very dehydrated, won't be enough. You'll need to give more fluid. And then you start thinking, well, this child's got severe dehydration and we need to correct their dehydration and work out what their deficit is and their maintenance fluid and the replacement for ongoing losses. Do they need oxygen? Almost all children in shock need oxygen. You saw the child I showed you at the start getting a double source of oxygen to maintain oxygen saturations. Consider the question, which antibiotic is best? And usually when we've got a child with shock, we'll be covering both gram-positive infections and gram-negative infections, like with flucloxacillin for gram-positive infections, or cloxacillin and ceftriaxone for gram-negative infections. That's justified in a child with shock to use those antibiotics. But also think to yourself, well, could this child have a multi-resistant organism? Could they have MRSA or could they have a multi-resistant gram-negative infection? And unfortunately, at the moment, we've got a number of children who have community-acquired MRSA. And so we need to be alert to those children that have community-acquired methicillin-resistant Staph aureus. It's more common than we think in all countries throughout the world, and it's certainly been identified in Chimbu, at least in patients with osteomyelitis, and it's been seen in Port Moresby. There's a number of children who've had community-acquired MRSA. So always think which antibiotic is best for the type of condition the child has, and consider where they might have a multi-resistant organism. You need to consider how to best control the source of the infection. Do they have a pleural effusion or an empyema that needs to be drained? Do they have a septic arthritis that needs to be drained, or a pyomyositis, a muscle abscess that needs to be drained? Do they need an antimalarial empirically? Should we put them on antimalarial agents just so as in case they've got malaria as well? Should we cover for that? Do they need a blood transfusion? If their hemoglobin's below about 7 in a child with shock, then I would always transfuse them. You don't need to wait until it's less than 5 or less than 6. I think if a child's in shock, they could benefit from having a somewhat higher hemoglobin. And then do they need an inotrope? Would they benefit from, they've had a lot of fluid by now while you're thinking about it and treating them with fluid and antibiotics, but would they benefit from some adrenaline? And I'll explain how to do that. If their cardiac output is poor, or their shock is unresponsive to the first fluid bolus. On the other hand, if they've got edema, if they're swollen and if their lungs seem wet, then sometimes putting them on some diuretics can help. Give them a decent dose of diuretics, a milligram per kilogram or 2 milligrams per kilogram of frusemide, and you'll sometimes get rid of some of that lung water and make their lungs better and make them less hypoxic. Do they need some positive pressure ventilation? Do they need to be on CPAP if they're hypoxic despite oxygen? And then consider what their potassium is. For example, if they've had diarrhea, lots of diarrhea, their potassium might be very low. Or do they need some calcium to support their heart function, or some bicarbonate because they've got a severe acidosis? Do they need an anti-venom if you suspect they might have snake bite? And do they need steroids? For many cases of septic shock, we would give a boost of steroids, and that would often help. And then do they need an echocardiograph to assess their cardiac function? So there's many questions that you can ask yourself as you're treating these patients, and that can help you manage them in the second and the third hour. And that's the reason why I go through these. I mentioned adrenaline, and I wanted to just explain how to give that, because sometimes you might think adrenaline needs to be just given through like a central line in an ICU, but you can actually give it through a peripheral line. As long as it's a good peripheral line, you need to be clear that it's a good vein, you put in a good cannula, you can aspirate blood from it, and that's safe to have adrenaline, at least for 4 to 8 hours, no problem. You can give adrenaline through that. And this is the way you can make it up. If you put 6 milligrams of adrenaline in 1 litre, 6 milligrams is 6 vials, put that in 1 litre of normal saline. And then if you run that in an adult, you run it at 50 mils an hour. In a child more than 12 years, run it at 20 mils an hour. In a child who's between 4 and 12 years, run it at 10 mils an hour. And a child less than 4, just run it at 5 mils an hour. And what that does for the average weight of that child, give them about 0.04 micrograms per kilogram per minute. And that's 0.04 or 0.05. And that's the right dose to start giving peripheral adrenaline. So that's a useful way to give peripheral adrenaline. Remember, we give it to children who've got hypotension despite a volume, an infusion of fluid over 30 to 60 minutes, or in children who've got heart failure. They can benefit from a peripheral infusion of adrenaline for a few hours, and then by that stage, you've started their antibiotics, you've got them on the right therapy, you may have done an echo to look at their heart function, and then you can decide to continue it on or not. And then lastly, in the management of children with shock, you should ask for help. You can never manage a child in shock by yourself. It takes a team of people to manage a child in shock, to do all of those things the child needs in the first hour or two. You should ask for help. You should manage the patient in an intensive care area, even if it's just a part of your ward where you've got a pediatric monitor, like one of these monitors, and you can use a monitoring and response chart to monitor their progress throughout. You can bring them 30 degrees head up so they're less likely to aspirate. You can do a whole lot of things in a normal ward that's got an intensive care area to manage the child with shock, even if you don't have an intensive care unit. But make sure you ask for help and get some senior people to see the child and make their assessment, and you can decide what treatment is best for the child. All right. So I really just wanted today to talk about fluid management of the child with shock. But as you can see, it's a lot more than just fluid management, and there's a lot of other things that we need to do. And you need to be thinking about the best type of treatments to give in the first hour and then what to give in the second hour. But that, I just wanted to explain that, a bit of background pathophysiology for those who are doing the part one, and a bit of clinical medicine for those, for all of us. Okay, so I'm going to stop the recording now, and I'm happy to answer any questions that you might have about the management of shock. Okay, thanks.